you may require several settings to make a diagnosis, and sometimes it so happens that you have to change your diagnosis after some years. So you have to be very vigilant during the diagnosis of arthritis and their follow-up, and you have to be follow-up for even lifelong. With this short introduction, we are going to start the slides. What are the key terms used in rheumatology? These are the key terms you will have to be acquainted with. These are the terms. Arthralgia. What is arthralgia? Arthralgia is joint pain, no inflammation. But arthritis is a joint inflammation. You have already taught in your pathology classes what are the signs of inflammation. You know that rubor, color, tumor, you have learned that swelling, redness, tenderness, these are the signs of inflammations. So when there is signs of inflammations are present, we call it arthritis. When only pain, no signs of inflammation, we call it arthralgia. So main point of difference is swelling. When there is swelling, we call it arthritis. When there is a swelling, only pain, no swelling, we call it a arthralgia. Please stop talking. Please stop talking. Try to listen. Other terms are there like periarthritis, inflammation of the periarticular structure like tendons, bones and ligaments. There are other terms also used are dactylitis. Dactylitis, the whole finger is inflamed, so it looks like a sausage. It is sausage type finger. It is called when it is called dactylitis. It is the features of psoriatic arthritis. This PSA, the short form is used, or it is found in psoriatic arthritis. Another is enthesitis, very important. Can you see it? Enthesitis. It is the inflammation of the enthesis, where the tendon attached to the bone. When the tendon is attached to the bone, that junction is called enthesis. That inflammation of that particular, it is called enthesitis. The enthesitis term is important. It will come in several times in your rheumatology classes. So these are the terms used in rheumatology. Mainly arthritis and arthritis. You may be asked in your exam what is the difference between arthritis. Why do you call it as arthritis, not arthralgia? Arthritis is the inflammation, pain and swelling. Other features may be present like redness and tenderness. But arthralgia is a pain of the joints but no swelling. Now approach to a patient with arthritis. To diagnose arthritis, answer these key questions. What are the questions? It is articular or systemic disease. You know many systemic diseases you have experienced that during fever there is pain in the joints during fever. So systemic disease can cause arthralgia, and you know that the dengue fever. And the name of the other name of the dengue fever is breakbone disease. So much pain in the joints that it is also another name is breakbone disease. The bones are breaking, like that feeling. So this dengue fever can also cause severe arthralgia. but that is not arthritis. So a systemic disease can cause joint pain. That is an arthritis. That is so it is articular or systemic disease. First you will have to determine. Second question is articular or periarticular? Articular means the joint structure includes the synovium, the cartilages and also the adjoining bone. But other structures outside the joint like your tendon or other capsules, like these periarticular structures are the surrounding joint structures are periarticular structures, they are called periarticular. So I will have to determine this is articular or periarticular structures are involved. Then you determine whether it is acute or chronic. Symptoms more than 6 weeks, you call it a chronic arthritis. Symptoms less than 6 weeks is the acute arthritis. Inflammatory or non-inflammatory, very important point. Inflammatory or non-inflammatory. What are the signs of inflammation? I have already taught there is a swelling, redness, etc. But in case of joint pain, joint diseases, morning stiffness is a very important sign for inflammation. Morning stiffness is patient cannot move his joints properly, cannot move properly, cannot walk properly in the morning hours. After sometimes after half an hour or 1 hour, he can move he can clench his fist, but at the morning, after he waking, after she is wake up, he cannot clench his fist. He cannot make flexions. Gradually, after 1 hour, half an hour, this is called morning stiffness. The duration of morning stiffness is a very important indicator for activity of the disease. So, it is morning stiffness is the additional factor for articular diseases as other you know that swelling, warmth and redness you know. Pattern of joint involvement. This is important. We call it these terminologies are important. You should be acquainted with. This monoarticular is only single joint involved. This is monoarticular. It is called oligoarticular when 2 to 4 joints are involved, and it is polyarticular when more than 5 joints are involved. So, it may be monoarticular, oligoarticular or polyarticular. It may be peripheral or axial joints. Peripheral joints, you know that these hands and feet joints are peripheral joints, and the spine and sacroiliac joints, these are the vertebral joints, the sacroiliac joints, these are the axial joints. Because many diseases has tendency to affect the spondyle, this we call it a spondyloarthritis. When these diseases affecting the spine and the sacroiliac joint particularly, we call it a spondyloarthritis, or it may be peripheral arthritis. Small or large joint, fingers are small joints, but knee, hip joints and shoulder joints are large joints. Whether it is symmetrical or asymmetrical, when same joints in the both side left and right is involved, it is called symmetrical. When it is not that, it is called asymmetrical involvement. So, you will have to if a joint pain comes in your study, you will have to ask all these questions. All these questions you have to ask, then you can only determine it is a arthritis or not a arthritis. Sometimes you know that sometimes if suppose this is a shoulder, patient has come with a shoulder pain, it may be arthritis, it may be due to the capsulitis, we call it frozen shoulder. It may be a referred pain due to the gallbladder disease, you know that gallbladder disease can refer to the right shoulder. So, it may be a referred pain also, that is not arthritis. So, joint pain is not arthritis. If only the joint structures are involved, we call classification of rheumatic diseases. So, we can classify diseases like inflammatory and non-inflammatory diseases. So, non-inflammatory rheumatic diseases are classical example is osteoarthritis. Osteoarthritis is non-inflammatory. The name signifies it is non-inflammatory means you will not get the signs of inflammation. Now, if it is osteoarthritis of the knee or osteoarthritis of finger, the signs of inflammation you will not get. And inflammatory arthritis. Inflammatory arthritis, you will get the signs of inflammation. It may involve the joints, we call it rheumatoid arthritis. It may be seronegative spondyloarthritis, psoriatic arthritis. These are all called inflammatory arthritis. Inflammatory, not only inflammatory arthritis, inflammation can involve the muscle also. We call it inflammatory muscle disease or myopathies, dermatomyositis and polymyositis. These are the inflammatory muscle disease. And vasculitis is the vessels, involved vessels. The same and process, pathological process in the rheumatic diseases can involve the muscle, we call it dermatomyositis, polymyositis. The same inflammatory process when it involves the vessel, we call it a vasculitis. You can see it is similar to the previous slide, but only one thing is added, that fibromyalgia. It is a very common disease, fibromyalgia. Where we will classify it, inflammatory or non-inflammatory? Yes, it is we should classify it as a non-articular, non-inflammatory disease. This is non-articular, non-inflammatory classification is fibromyalgia. There is a widespread muscle involvement, pain and tenderness in case of fibromyalgia. It is a very common disease we face, fibromyalgia. Now, our subject of discussion today is inflammatory rheumatic disease. What are the inflammatory rheumatic disease? These are rheumatoid arthritis, systemic lupus erythematosus. There is seronegative spondyloarthritis. I have told you this involves the central joints. Spondyloarthritis means involvement of the spine and the sacroiliac joint. Systemic sclerosis is also a disease where there is tightening of skin and connective tissue. Sjogren's syndrome, you know the Sjogren, this should be uttered as Sjogren, but we commonly utter it as a Sjogren. So, it is a Sjogren's syndrome, affects the affects the moisture producing glands like dry mouth and dry eyes. So, there is lymphocytic infiltration in the Sjogren's syndrome. Due to inflammation, there is inflammatory, there is lymphocytic infiltration in the salivary glands. So, there is dry mouth and dry eyes and lacrimal glands also. So, these are there. So, inflammatory myopathies, dermatomyositis, polymyositis, I have already mentioned. Juvenile rheumatoid arthritis is autoimmune arthritis in children. Vasculitis, I have mentioned that vessels sometimes involved in these rheumatic diseases. Now, our point of discussion is rheumatoid arthritis. So, students, rheumatoid arthritis and rheumatic fever is altogether a different disease. I have described the rheumatic arthritis in our previous classes. During our, if you can remember, in our discussion in our chorea, when we described the chorea, we also given some points about rheumatic fever. The rheumatic fever is a post-streptococcal infection, is altogether a different disease. Never confuse with rheumatic fever with rheumatoid arthritis. These two diseases are altogether a different disease. So, rheumatic fever is a post-streptococcal disease. Anti-streptolysin O antibody produced against streptococcus, that produces arthritis, that produces chorea. We call it a synonymous chorea, and also it involves the joint also we call it migratory polyarthritis. These are the actually this is in response to the infection of the streptococcus. But rheumatoid arthritis is altogether a different disease. There is no relation between rheumatic fever, rheumatic arthritis and rheumatoid arthritis. So, rheumatoid arthritis. So, articular manifestations. Though the names are similar, but God's sake, don't confuse it. Rheumatoid arthritis. So, what are the articular manifestations? That is the joint involvement, usually symmetric. Symmetric means I have told you how to classify is asymmetric or symmetric. There was one classification. So, it will fall under symmetric polyarthritis. It is symmetric means both sides of the body involved equally. So, it is symmetric. If the left hand is involved, the right hand is also likely to be involved within a few days or few months. So, it is a joint involvement is symmetric. It is characterized by pain, swelling, tenderness and limitation of movement. All the signs of inflammation I have already told. Then this metacarpophalangeal joint and proximal interphalangeal joint. This MCP is metacarpophalangeal joint and the PIP is proximal interphalangeal joints of the hands, wrist, knee and the metatarsophalangeal joint and the proximal interphalangeal joints in the foot are also involved in this disease. But you can notice it that distal interphalangeal joint is conspicuously absent here. So, distal interphalangeal joints almost always never involved in rheumatoid arthritis. Distal interphalangeal joints means this joint, distal interphalangeal, this is middle, distal interphalangeal joint, the last terminal joints of your finger, that is the distal interphalangeal is always never involved in rheumatoid arthritis. It involves in other diseases like osteoarthritis, like your psoriatic arthritis. These are the main involvement of the distal interphalangeal joint. But in rheumatoid arthritis, it is not involved. So, generalized stiffness may be there, we call it morning stiffness, you know all these things lasting for more than 1 hour. If this morning stiffness is last for more than 1 hour, we call it a significant stiffness. It will help your diagnosis of rheumatoid arthritis. So, what are the structures involved? I have already told you that the hands and wrist. Hand and wrist are involved. It is if you can read it from the distance, student can. In our classes, we used to sit in the first benches, but I noticed that you have the tendency to sit in last benches. First benches are all empty. Anyway, so this is hand. You cannot see it properly. From the last benches, it is difficult to see the slides. Anyway, so hands and wrist are involved. Swelling and proximal of the inflammation, there is a spindling of the fingers. These fingers are this in middle interphalangeal joint and the proximal interphalangeal looks like a spindle. It is spindle shaped joints. Then this hyperextension of and proximal fingers. This if you can read it. So these are the deformities. These are the deformities you will have to remember. This is called Swan neck deformities. This is hyperextension of the proximal joint and it produces swan neck deformity. Then also there is Boutonnière deformity. There is flexion of the proximal interphalangeal joint, and also there is extension of the distal interphalangeal joint. That causes Boutonnière deformity. I will show you pictures in the next slide. So just read it. Hyperextension of the finger, this is another deformity. Flexion, the deformity. Another deformity is dropped fingers. When there is deformity called dropped finger. Another deformity is the radial deviation of the wrist and ulnar deviation of the digits, that causes a jet deformity in the wrist. I will show you pictures in the next slide. Wrist synovitis and the median nerve entrapment is called carpal tunnel syndrome. You know, the carpal tunnel syndrome is a compression of the medial nerve at the wrist. That is called carpal tunnel syndrome. Carpal tunnel syndrome has many causes. Sometimes it comes as it also comes as a short note, carpal tunnel syndrome. Other than rheumatoid arthritis is the important cause, definitely. Other than rheumatoid arthritis, it can also occur in pregnancy. It can occur in hypothyroidism. It occurs in many diseases actually. So, rheumatoid arthritis, pregnancy, hypothyroidism, you will have to remember, and also occurs in diabetes. Diabetes mellitus. This is a common cause of carpal tunnel syndrome. What are the features? There is compression of the medial nerve at the wrist. You know that medial nerve supplies the radial side of the hand. It supplies the 3.5 radial side 3.5, but it don't supply the medial side 1.5 fingers. That is supplied by ulnar nerve. So if there is a medial nerve lesion, you will get a paresthesia or anesthesia in the radial half of the finger. Okay, radial half of the palm. But sometimes the thinner eminence and that palm is sometimes spared because there is another cutaneous nerve, palmar cutaneous nerve by the same median nerve, but that comes it sends a twig before it reaches the wrist. So that is sometimes this area sometimes spared because the palmar cutaneous nerve or the median. Anyway, so you will have to remember this. The carpal tunnel syndrome sometimes comes as a short note. You will have to write what it is, what are the findings, and what are the important causes. So this is carpal tunnel syndrome. Anyway, it is the important cause is rheumatoid arthritis is the important cause. These synovitis can be called carpal tunnel syndrome. Here, which of the hand may be swollen, and it is called a boxing gloves appearance. These all terms are there. These terms are interesting to remember. But some deformities I will show you in the next picture. You will have to remember at least this thing. These hands, deformity. This you can see the pictures from the distant people. So you cannot see if you have no interest. I have no interest to show you. Anyway, if you can see it, deformity is that you see the joint is affected. Here there is a swelling in the PIP joints. There is a proximal interphalangeal joints are swelled. Swan neck deformity, there is hyperextension of the PIP, and there is the flexion of the DIP. This is called swan neck deformity. You can see it, swan neck deformity. But I have told you the distal interphalangeal joints are not involved. But here is the flexion of the distal interphalangeal joints. The question may come to your mind, sir, why the distal interphalangeal joint is deformed? Because it is due to the pulling of the tendon, not due to direct arthritis. This distal interphalangeal joint swan neck deformity I have told you that distal interphalangeal is never involved. So, but this is due to the tendon pulling, not due to the direct arthritis. This distal interphalangeal joint involvement. Anyway, this Boutonnière deformity is there. This is the Boutonnière deformity. There is a flexion of the interphalangeal joint, and there is mild extension at the distal interphalangeal joint that causes this Boutonnière deformity. And trigger finger. Sometimes a rheumatic nodule like this forms in the tendon, and trigger finger, the finger stucks when there is a trigger like movement, patient does the finger stucks, that is called trigger finger. That also occurs in rheumatoid arthritis. These are deformities. These are the deformities in the wrist. Deformity, you see, there is a joint affected. This is ulnar deviation. You can see the wrist. There is an ulnar deviation of the wrist joint, the fingers, and the metacarpophalangeal joints associated with deviation of the radiocarpal joints. This causes this type of deformities. This is a caput ulnari. This is called this is ulnar side of the is a swelling. There is a ulnar side. This is called caput ulnari, and there is a boggy synovium. Synovium is enlarged. Synovium is thickened. You can feel it from your finger from the outside. The synovium is thickened. And lastly there is CTS or the carpal tunnel syndrome that are there. Similar, these are the deformities. I have already told you there is a deviations of this causes this type of deformity in the wrist. Now foot and ankles are also involved. This type of deformities can occur in the foot and ankle. There is swelling, the lateral deviation of the plantar subluxation, there is eversion of the hand and foot, and there is hallux valgus. Hallux valgus is also a deformity occurs in these patients. It makes the patient to wear his or her shoes. Hallux valgus means the great toe is deviating outside, sometimes making it difficult to wear the shoes. Now this is important, this is interesting. What is the etiology? If you go to the etiology of the rheumatoid arthritis, usually there is a genetic predisposition is there, and a genetic predisposition is HLA-DR4. That human leukocytic antigen. There are human leukocytic antigens. You know, there are different. They are major histocompatibility. Probably you have learned in your pathology classes. They are the major histocompatibility complex (MHC). There are two types: MHC 1, 2. 1, 2, 3 are MHC 1, DR1, DR2, DR3 is MHC, major histocompatibility complex 1, MHC 1, and 4 is a MHC 2 or major histocompatibility complex 2 is a DR4. Anyway, this is MHC 2, DR4 is a genetic predisposition that is affected, and there should be a genetic predisposition of HLA-DR4. And this HLA-DR4, but their environmental factors should be there. This all two together starts this autoimmune process. Environmental factors should be there. You know that one disease is chikungunya. Classical example is chikungunya fever. You probably have heard this chikungunya fever. You know, chikungunya. Chikungunya, you have probably heard this disease. These are disease classically sometimes present as a bilateral symmetrical arthritis, like rheumatoid arthritis. Very common presentation of this chikungunya. Sometimes the infection is recovered from the infections. Sometimes after the patient comes with the rheumatoid arthritis. So here the classical example where this infectious this environment activates the disease process. So anyway, so so etiology is that there is activation of the disease process. What activation is causes? T lymphocytes. T lymphocytes, you know that this MHC major histocompatibility complex 2, it activates the CD4. CD4 lymphocytes. CD4 are the lymphocyte. CD4 is a clustered. The CD4 lymphocytes usually it activates the CD4, then the T lymphocytes. That will produce what? This interleukin 2. Interleukin 6, interleukin 1, these are the inflammatory cytokines. They are called inflammatory cytokines. And also TNF, tumor necrosis. These are the inflammatory cytokines produced by the T lymphocyte. That what T lymphocytes? CD4 T lymphocytes. That is activated by MHC. And this MHC1 in your pathological is that activates the CD8, not CD4. Anyway, this activation causes what is the macrophage is also activated. That causes macrophage activation causes interleukin 6. And also interleukin 8. That interleukin 6, what it also produce? The fast reactant, APR, the acute fast reactant. There are several acute fast reactant. There are several acute fast reactant. Because this interleukin 6 is interleukin 6 is activated in many diseases, many infectious diseases also. Many infectious diseases also. These are acute fast reactant, APR, acute fast reactant. The commonest acute fast reactant is CRP, C-reactive protein. Other are fibrinogen. Others are many there. Ferritin. So there are several fast reactants. On the many things are there. Hepcidin. These fast reactions, hepcidin causes anemia. If there is anemia of chronic disease, any chronic disease can cause anemia because of the same procedure. The interleukin 6 is activated. Interleukin 6 goes to the liver. Liver produces a protein called hepcidin that causes anemia. Bone marrow suppression and anemia. So these are called acute fast reactant. Acute fast reactant may come as the short note also. Just acute fast reactant. You will have to write all these things. How this interleukin 6 is activated and it goes to the liver and produces some proteins. C-reactive protein, fibrinogen, ferritin, hepcidin, like this. There are other also. Anyway, remember these things. So these things, those acute fast reactants are there. APR. Then B lymphocyte is also activated. You know that B lymphocyte produces an antibody that produces the antigen antibody complex that is deposited. That is the immune complex disease. That is activation by the B lymphocytes. So all these things are activated. T lymphocyte, there is activation of the macrophages, then activation of T lymphocyte. So all this pathogenesis is produced and resulting in what now in a rheumatoid arthritis. Now, what investigation should do in a rheumatoid arthritis patient? You can read, if you can read it. First, there is a ESR. ESR is also increased it is also considered as a fast reactant. ESR is increased in any inflammation. So ESR is increased. There is anemia. I have already told. There is a hepcidin produces this anemia. There is thrombocytosis, and there is increased level of acute fast reactants. APR that I have already described. C-reactive protein and increased plasma viscosity. That is rheumatoid. There is rheumatoid factor. Rheumatoid factor is also rheumatoid factor. Very important. Rheumatoid factor. What it is? It is the IgM produced against his own IgG. So rheumatoid factor is the IgM. It also comes as MCQ. Most of the students cannot answer these MCQs. The rheumatoid factor is the IgM. Why it is produced? It is produced against own IgG. Patient's own IgG. There are very few diseases where this IgM produced against his own IgG. Anyway, the rheumatoid arthritis is one where IgM this is called rheumatoid factor. So rheumatoid factor also found in that's why it is found in many diseases. Rheumatoid factor is not only found in rheumatoid arthritis, it can found in many diseases as it is a IgM produced against his own IgG. Now there is another is anti-citrulline protein antibody, ACPA. Also we call it anti-CCP antibody. Anti-CCP antibody, what happens in the chromosome, there is arginine. This arginine by some enzymatic process is converted into another amino acid called citrulline. That is normally not present in the body, but this arginine by some enzymatic process is converted into citrulline. That's why the body will not tolerate it. It will produce an antibody against this citrulline, which is called antibody against this citrulline. So this will cause the anti-CCP. They will also call this a anti-citrullinate. That's why it is called anti-citrullinate antibody or anti-citrullinate antibody, or it is also called a anti-CCP antibody, commonly call it. Better to call it as a ACPA, anti-citrulline protein antibodies. Better to call it as ACPA, but we used the term previously, it is anti-CCP antibody. Better term is ACPA. Anyway, the radiograph of the affected joints, you can do a X-ray. What we will find, there is a juxta-articular osteoporosis, very hallmark finding of rheumatoid arthritis. Juxta-articular osteoporosis. I have one picture, I will show you. There is a juxta-articular osteoporosis. There is soft tissue swelling. There is bone erosions and joints. Bone erosion is a hallmark of rheumatoid arthritis. Okay. The ultrasonography and MRI will give you better sensitivity to see the joint swellings. Rarely, Honeywell fluid analysis and biopsy are sometimes required. So, diagnosis of rheumatoid arthritis, there is a EULAR criteria, European criteria, and American College of Rheumatology criteria. There is a, both are this criteria for rheumatoid arthritis diagnosis. You will have to remember it. What are the features? There is a total activity, total score is 10. Total score is 10, and if the patient gets 6 out of 10, then we make a diagnosis of rheumatoid arthritis. Then what are the joint involvement? Features are joint involvement. One large joint involvement, good 0. So if it comes with a patient with a single monoarticular arthritis, knee joint involvement, 0. Score is 0. It is not a rheumatoid arthritis. 2 to 10 small joints, it is 1. It is written in your book. If you are not interested, I will pass up this slide. You have increased your gossiping. I think you are not interested about these slides. Leave it. So this serology I have told you, there's this ACPA and CCP antibody that will get it to 2 and high positive RA factor we got a 3. Acute fast reactant CRP ESR I have told you that will get a 0. If it is if ESR is increased or CRP is increased, get 1. Duration is more than 6 weeks. Usually we cannot diagnose the case of rheumatoid arthritis before 6 weeks. So if it is more than 6 weeks, we give you 1, and the total number score is more than 6 out of 10, then we make a diagnosis of rheumatoid arthritis. The rheumatoid arthritis not only involves the joints, it also involves the extra-articular structures also. These are the pictures you can see what are the extra-articular structure involved. There is anemia of chronic disease. I have told you the extra-articular manifestations. There are other extra-articular manifestations like in the eye, it is episcleritis, and starting from eye you can remember if you started from above down, you can remember. So episcleritis and scleritis are there, keratoconjunctivitis, sicca. It is keratoconjunctivitis, sicca terms is used in many diseases in rheumatology, keratoconjunctivitis, sicca. This term is used because it is because of lymphocytic infiltration in the salivary glands, also the lacrimal glands, causing less lacrimation and less salivation. So there is also can be lymphadenopathy. There may be osteoporosis. There may be these lungs can be involved, like pleurisy, fibrosis, and effusions can be involved. And pericardial infusion, pericardial effusion may be there in the rheumatoid arthritis. Rheumatoid nodules. There rheumatoid nodules are also there may be in the elbows and lungs. And Felty syndrome, I will come on side is there. The rheumatoid arthritis is splenomegaly and neutropenia. When there is combinations is there, we call it as a Felty syndrome. There is rheumatoid arthritis, splenomegaly with neutropenia, called as a Felty syndrome. And Raynaud's disease, you know, the Raynaud's disease, carpal tunnel syndrome, and peripheral neuropathies. These are all extra-articular manifestations of rheumatoid arthritis, other than articular manifestation. And vasculitis, of course, there occurs in almost any collagen vascular disease. So these are the extra-articular manifestations. If you see the pictures, this is a typical scleritis. See the sclera is very much inflamed and red looking. This is episcleritis. Scleritis and episcleritis. Sicca complex is there, may be there, and the patient also may suffer from glaucoma. Rheumatoid vasculitis, I have already told, vasculitis look like this. There is petechial spots in the skin. Vasculitis presents as petechial spots in the skin. You see these petechial spots in the skin in the patients, the petechial spot in the skin. So these are the presence of vasculitis. Polyneuropathy and maybe vasculitis may be present. Polyneuropathy and mononeuritis multiplex. Polyneuropathy is a symmetrical and mononeuritis multiplex is a asymmetrical patchy involvement. The same, when there is asymmetrical patchy involvement, we call it mononeuritis multiplex, or when there is symmetrical involvement, we call it the polyneuropathy. Cutaneous ulcerations may be palpable, pura and distal gangrene. This cutaneous ulceration and distal gangrene is a hallmark of scleroderma. Another disease, you know that PSS, progressive systemic sclerosis, also called scleroderma. They have these features of digital gangrene. Some diseases, some symptoms, some signs are particular to some diseases, but can occur in any of the diseases. So this digital gangrene is a hallmark of systemic sclerosis, but can also occur in rheumatoid arthritis. Visceral, there is visceral infarction causing stroke and myocardial infarctions may be there because of vasculitis. Vasculitis can cause stroke, can cause myocardial infarction also. So these are the pulmonary manifestation of rheumatoid disease. This pleural involvement is there, resulting in effusions, and this pleural effusion is characteristically have a very low glucose. Cause is not known, but usually you get a very low glucose in a infection. So there is infections. When there is infection, it is called a parapneumonic infusion. Parapneumonic, also called a thin pneumonic. When there is pyogenic bacteria causing this pleural effusion, that has a low sugar, you know. But another disease like rheumatoid arthritis can also have a very low sugar in pleural fluid. Pulmonary involvement resulting in interstitial fibrosis, and there is Caplan syndrome. Interstitial fibrosis. Anyway, don't need go. There are two types of interstitial fibrosis for your MCQ for further. Not now. If you can remember it, you can answer your MCQ in your after. At this stage, there are several types of fibrosis in lung. There are mainly two types. One is UIP, one is NSIP. Okay, this rheumatoid arthritis causes UIP, not NSIP. This is one important MCQ in your postgraduate. Anyway, sure, let's leave it there. Caplan syndrome. Caplan syndrome is Caplan syndrome. You know, is that there is a features of when there is a rheumatoid arthritis with the features of environmental lung disease like pneumoconiosis, because these combinations are there. That's why it is called Caplan syndrome. When the patient has rheumatoid arthritis with some environmental lung disease like the pneumoconiosis or silicosis. Silicosis is also important. We saw that the silicosis by patient working in asbestos factory. He has come. I have seen patients working in asbestos factory come with rheumatoid arthritis, having lung disease also. So this is a Caplan syndrome, and there is lung interstitial fibrosis. Cardiovascular manifestations, there is pericarditis and chronic constrictive pericarditis also there, and the pericardial effusion I have already told you. There may be valvular involvement and conduction defects also. These are the cardiac involvements can occur in a rheumatoid arthritis patient. But cardiac involvement can also occur as a rheumatic fever. I have told you not to confuse with these two diseases. Rheumatic fever also causes valvular heart disease and all. That is very common in that rheumatic fever, but rheumatoid arthritis heart disease is not common, but it can occur. Neurological manifestation, non-impairment, I have already told the carpal tunnel syndrome, spinal compression. At very important, this second point is very important. At the spinal joints, I have told you is not involved in rheumatoid arthritis. This is spondyloarthritis. Arthritis is involved in ankylosing spondylitis, not rheumatoid arthritis, but only one joint involved in the central nerve, in the central vertebra. There is a vertebral column. There is one joint is very involved. There is except this atlantoaxial joint. Atlantoaxial joint is involved in rheumatoid arthritis. There is only joint in the central joints exceptions. Sometimes it causes an emergency because it can cause atlantoaxial subluxation that can kill the patient, that can compress the medulla. Atlantoaxial joint subluxation, the odontoid process will hit the medulla, and if you can hit the respiratory center, patient may have a sudden death. So these are acute emergencies. If you in your future studies you will study some acute emergencies are there in a rheumatoid arthritis, but this is one acute emergency. That is atlantoaxial joint involvement, and there is peripheral neuropathy. I have told you. Now osteoporosis. This is osteopathy. This joint is involved, and there is periarticular osteoporosis. Periarticular osteoporosis, I have told you, it is a hallmark of rheumatoid arthritis. Other joints may be involved. You have told you that cervical spine involvement, cricoarytenoid joints, cricoarytenoid joints may be involved. These are rare but involved. Involvement may be there. These are there. Other joints involvement. Now, Felty syndrome I already described you. The rheumatoid arthritis is splenomegaly with neutropenia. There is splenomegaly and neutropenia. There is splenomegaly and neutropenia. Now, these are chronic inflammations. Signs of chronic inflammations you can get in a rheumatoid arthritis. There is a constitutional fevers, etc. The symptoms. There is increased signs of atherosclerosis, and there is secondary amyloidosis. Secondary amyloidosis occurs in many diseases. Rheumatoid arthritis is a disease. This activation of these interleukins that causes the amyloid protein also. I have told you several proteins are secreted by the liver due to activation of these interleukins. Amyloid proteins can also produce, and chronic amyloidosis is a complications of many diseases. It can also rheumatoid arthritis also. Now come to the management. What management you can do for rheumatoid arthritis? Rest and splinting is a joint. Joint is important at the acute phase. In active and passive physiotherapy, you can do analgesic, non-steroidal anti-inflammatory drugs, aspirin, ibuprofen, diclofenac, naproxens, all these anti-inflammatory drugs, NSAID, non-steroidal anti-inflammatory drugs. Because steroid also is an anti-inflammatory drug, but these are NSAID, non-steroidal. That's are used in the you can use in the acute stage. Now, DMARD is very important. DMARD is disease modifying agents. These are specific for rheumatoid arthritis. We use it in a disease modifying agents. Rheumatoid arthritis, what they use? Many are there, but you have to remember few. Like you should remember a methotrexate. Methotrexate you should remember. Leflunomide you should remember, and hydroxychloroquine and hydroxychloroquine. Here it is hydroxychloroquine. You should remember. You should remember this sulfasalazine, methotrexate, and leflunomide. These four you should remember at least. If you cannot remember all this, gold penicillamine, no matter, but you have to remember at least four: hydroxychloroquine, this sulfasalazine, methotrexate, and leflunomide. These four you should remember as a DMARD, disease modifying agents used in case of rheumatoid arthritis. Now come to the methotrexate. Methotrexate is the most common used drug in rheumatoid arthritis. You should know it in some details. Like you currently issue, there is the drug of choice in rheumatoid arthritis. Hydroxychloroquine can be used with hydroxychloroquine, or it may be used along with hydroxychloroquine. Methotrexate, the usual starting dose is 7.5 to 10 milligram orally weekly. It is given weekly, okay. But the desired effect you may not get up to 4 to 6 weeks. Methotrexate, you know that methotrexate is a anti-neoplastic drugs that can cause bone marrow suppression also. That can cause bone marrow suppression. You have to look after this TCDC total counts in after some time, after some gap. You'll have to see it. And methotrexate also can cause folate trapping. It's a folate trapping agent. It reduces the folic acid. So you'll have to replace the folic acid. You replace the, otherwise patient will develop severe anemia, folic acid deficiency anemia. So you have to replace the folic acid time to time with this methotrexate. Give it to improve the methotrexate doses. But folic acid to be given high milligram at least once weekly. Some physicians prefer it giving more, twice weekly or even thrice weekly, but not in a methotrexate day. The patient should avoid the folic acid on the day he is taking the methotrexate. He should not take. Otherwise, folic acid will not act because it acts as a folate trapping agent. If you give a folic acid along with that, the methotrexate will not act. He should avoid it at least on the day of methotrexate the patient is taking. On other days, patient can take folic acid. It is usually given once or twice weekly. It is given. Other DMARDs, you know that the other DMARDs are also used. Leflunomide is important. Leflunomide is nowadays very much used. DMARD is leflunomide, and they are also used along with methotrexate also. When you cannot control it with methotrexate alone, we give it leflunomide, because hydroxychloroquine has a severe eye toxicity. You cannot give it for a prolonged time. Sulfasalazine is a sulfonamide. It has many toxicities like that. So, methotrexate you can use for a prolonged time. Leflunomide you can use for a prolonged time. No problem. Leflunomide, so it is a pyrimidine active antagonist that binds to this protein, DNA protein, and it is used in the doses of 10 to 20 milligram. It may be used along with methotrexate also. So corticosteroid is another drugs can be used, but corticosteroid should be used for a shorter period and at a low dose. In case of rheumatoid arthritis, corticosteroid should be used in a shorter period in a low dose. It is not used for a prolonged time, but you can use it corticosteroid in the active, particularly if there is a scleritis, scleritis, like that complications. You should use steroid for the acute phase of the disease. So steroid. Other important is nowadays very much discussed drugs are biologicals. These are also used in rheumatoid arthritis. What the biologicals are used? They block the specific immune complex. Anti-TNF-alpha. You have shown you that TNF, tumor necrosis factor, is important chemical agents in the pathogenetic process. So you can use anti-TNF-alpha drugs. What are the drugs? Infliximab, adalimumab. These are the drugs used for as a TNF-alpha. Rituximab is the anti-CD20 drug antibody that blocks the CD20 in the B cells. Tocilizumab is a monoclonal antibody that binds with interleukin 6. These all comes as in the process of pathogenesis. No, this is interleukin 6. It blocks the interleukin 6. Tocilizumab, and this it blocks the interleukin 6. This tocilizumab, that's why it is used in many infections also. This Boutonnière and this is anakinra receptor 1 blocker. Anakinra also interleukin 1 blocker. These are the drugs. Biologics are used in rheumatoid arthritis. Some details about infliximab. If you try to remember, you can. G1. This important point is there is important point in infliximab or use these drugs, biologics. There may be reactivation of the tuberculosis also. Patient if have a occult tuberculosis, that tuberculosis will be reactivated. So before embarking on these drugs, you should exclude the patient do not have any tuberculosis. Tests has to be done to exclude tuberculosis in these patients before giving these drugs. So reactivation of tuberculosis is a problem. You should exclude tuberculosis before giving this drug. Very important fact. Then etanercept, another it is a soluble etanercept. It is a soluble and adalimumab also a monoclonal antibody. I am passing the slide. Tofacitinib. Tofacitinib is nowadays very much used in a drug. This is a new class of drug. This is called JAK inhibitors. Okay, this is a genus kinase inhibitor, JAK inhibitor. Tofacitinib is nowadays very much used in a drug. Tofacitinib is used in other diseases also, like rheumatoid arthritis. Other than rheumatoid arthritis, it can be used in psoriatic arthritis and ulcerative colitis in inflammatory bowel disease. Ulcerative colitis, it is used. So tofacitinib nowadays are very much used drug in these disease conditions. These are JAK inhibitors or also genus kinase inhibitors. Now last is your surgical therapy. Surgical therapy is disfiguring lesions in the foot. Patient cannot wear foots. Patient cannot walk properly. Then you can go for a surgical correction of these deformities. Those are the options you can have.